Welcome to our session, What to Know About Healthcare Coverage. My name is Aaliyah McKinley, and I'm the Director of Education and Outreach for the Asclepius Initiative. The name is a bit of a tongue twister, but there were already so many wonderful organizations with the words Kentucky and health in their names. You may not be able to spell, pronounce, or remember it, but at least you'll recognize it if you see it again. Asclepius represents medicine and healing in Greek mythology. TAI's mission is to provide education and build support for the idea that everyone in the U.S. simply has continuous healthcare coverage from birth until death, so that you don't lose your insurance if you leave your job, get divorced from the policyholder, or move across state lines, events that can happen to any of us at one time or another. Despite spending 18% of gross domestic product on healthcare and over $14,000 per capita per year, which is 50% more than the next highest spending country, we have poor health. Compared to other high-income countries, the U.S. has the lowest life expectancy at birth, the greatest burden of chronic disease, the highest obesity rates, and the worst maternal and infant mortality. Just how broken is our system? Millions of people in our country are uninsured, and even more are underinsured. In our 2024 survey, TAI found that while 87% of those who are uninsured went without medical care or medications secondary to cost, this was also true of over 50% of those who were insured. Concerningly, with the cuts to Medicaid and the changes to the marketplace enacted in the OBBBA, an estimated 16 million Americans and 200,000 to 350,000 Kentuckians are projected to lose their health care coverage. In many cases, this will be a result of complicated and burdensome reporting requirements rather than lack of eligibility. The financial consequences are already huge. It is estimated that 2/3 of bankruptcies are a result of medical costs or time off work due to illness. It is reported that up to 80% of medical bills are incorrect, and approximately 20% of medical claims are denied. Kentucky is not a healthy state. We are 45th out of 51 in healthy lives, 46th in premature deaths from treatable causes, 47th in premature deaths from preventable causes, and 41st for people under 65 with high out-of-pocket costs relative to their annual household income. We also have the highest death rate from cancer, the second highest death rate from chronic lower respiratory illnesses, and the fourth highest teen birth rate. Finally, a brief note on the consequences of having no insurance at all. People without insurance are less likely to receive preventive care, see a healthcare professional for a medical need, follow through with medical recommendations, or fill their prescriptions. They're more likely to be hospitalized for avoidable problems, and when they're hospitalized, they get fewer tests and are more likely to die than people who have healthcare coverage. There are also serious financial consequences associated with being uninsured. Not only are people more likely to forego care if they aren't insured, but when they do receive care, it can be at the cost of being unable to purchase food, clothing, or other necessities. People who are uninsured often face unaffordable medical bills when they seek care. These bills can quickly translate into medical debt, since most people who are uninsured have low or moderate incomes and have little, if any, savings. Patients and their families are contacted by debt collectors about medical bills more than any other type of debt, and it commonly results in negative information appearing on credit records. In fact, in 2021, 43 million people had allegedly unpaid medical bills on their credit reports. An important thing to be aware of, though, is that since April 11th, 2023, large credit reporting agencies no longer report medical collection debts below $500. However, it takes almost nothing to get to that amount: a couple of labs, an ultrasound, a colonoscopy. Bankruptcy is another all too common result of not having health insurance. Two-thirds of bankruptcies in the United States are estimated to be due to medical costs or time off work due to illness. During this presentation, we'll review the risks of being uninsured, coverage options, understanding insurance documents, important terminology, and how you can save money on healthcare expenses. What do we mean when we say healthcare coverage? Healthcare coverage is how a third party covers payment for the healthcare services you receive. It's typically paid for either by an employer, the government, such as Medicare, Medicaid, TRICARE, and VA, or the insured themselves, which happens with the purchase of marketplace plans or through student health services. Insurance introduces a middleman between the person receiving the healthcare services and the person paying for them. If someone goes into the grocery store, for example, currency is exchanged directly for food. With commercial insurance coverage, the patient sees the doctor for care, but the insurance carrier determines how much and whether or not they'll pay for the proposed or delivered care. If the carrier spends less on care and overhead than they have collected in premiums, they get to keep the difference. As a general rule, the government interferes far less with a provider's recommendations than the private insurers do. There are multiple types of healthcare coverage in the US. Most people only qualify for one option at any given point in time, although there are individual circumstances where that may not be true. For example, if someone is over 65 but still has access to private coverage through their work. Each of these options has a different path to signing up. TRICARE coverage is a closed system limited to active duty service personnel, National Guard, and Reserve members, retirees, and their families. VA benefits apply to eligible veterans who have served in the armed forces, military, naval, and Air Force. VA coverage is primarily an integrated self-contained system, although patients can be referred to outside providers for services not available within the VA system. The Federal Employees Health Benefits Program covers federal civilian employees, retirees, and their families. Today, we will be focusing on Medicare, Medicaid, and commercial insurance. A key point to note is that all coverage programs require active enrollment. Coverage is not automatic. There are eligibility requirements, deadlines, and forms to fill out. The new rules in OBBBA will make this even more cumbersome than it already is. Coverage can be lost due to failure to pay premiums or life changes such as earning more than the Medicaid thresholds, switching jobs, getting divorced, the death of a spouse who is the policyholder, or moving across state lines. Healthcare coverage is really complicated. It can help to start by figuring out what your needs and options are. So here are some questions to keep in mind. What types of coverage are available to me? Is the plan an HMO, a PPO, or another type of coverage? How likely is it that I'll have healthcare expenses during the covered benefit period? Yeah, we're being asked to predict the future here to some extent, but this is how insurance always works. Do I qualify for subsidies, also known as premium tax credits or cost sharing reductions, which are only available on the marketplace? Who in my household needs to be insured? What's my health status and the health status of those in my household? Do my household members or I have any chronic health conditions or prescriptions that will affect my annual healthcare costs? Am I having any medical or emotional symptoms for which I do or will need evaluation and possible treatment? Will I need care outside of where I live? Will I or others in my household become Medicare eligible within the plan year? Does the plan have a flexible spending account or FSA, a health savings account or HSA, or a health reimbursement arrangement or HRA attached? We'll begin by reviewing some insurance terminology. Household. The marketplace generally considers your household to be you, your spouse if you're married, and your tax dependents. Premium is the amount paid per month for an insurance policy. Deductible is the annual amount that your insurance company requires you to pay for medical services before they'll start to pay for the care that you receive. Except for certain preventive services and those for which there's a copayment, commercial carriers typically will not pay for any healthcare services until you've met your deductible. Once the deductible has been met, you most likely will still be required to pay something for the healthcare services which you receive until you've met your out-of-pocket maximum. Copay, a fixed amount you may be required to pay for things like office visits, medications, emergency room visits, outpatient care, labs, surgeries, and the like prior to or after meeting your deductible. Coinsurance, a percentage amount of the allowed cost of your medical care that you're required to pay. For example, with an 80/20 plan, if the allowable for medical services was $100 and you had met your deductible, of the $100, you would pay 20% or $20, and your insurance would pay the remaining 80% or $80. Out-of-pocket maximum, which applies to individual and family coverage. This is the most that you can be required to pay for covered medical costs within a given plan benefit year, not including your monthly premium. This typically consists of the amount that you pay for deductibles, copays, and coinsurance. And now we have an example of how all of these numbers work together. Meet Kai. Meet Kai and his health insurance plan. Kai has a monthly premium of $300. Remember, the monthly premium is the subscription fee to keep the insurance active. Kai's annual deductible is $1,500. The annual deductible is what Kai pays for covered services, excluding preventive care, before insurance kicks in. Kai's coinsurance is 20%. This is a common 80/20 plan, so Kai's share of costs will be 20% after the deductible is met. Kai's out-of-pocket maximum, or MOOP, is $7,500. This is the absolute limit Kai will pay for covered services in a plan year. Note that premiums do not count towards the deductible or out-of-pocket maximum. As we all know, accidents happen. Kai was finally tackling the big chore he'd been putting off, cleaning out the gutters before an incoming rainstorm. Everything was going fine until the very last corner of the house. The ladder hit a patch of wet grass. Kai lost his balance, took a tumble, and ended up with a broken arm. One surgery later, Kai is on the couch with a $30,000 bill that he never planned for. Now that Kai is recovering, let's look at how his accident will impact his finances. The hospital charges for Kai's surgery total $30,000. Kai's allowable, the most that the hospital can collect as an in-network provider for ER, surgery, and cast is $10,000. Kai's deductible, or how much Kai must pay in a given year before insurance will pay for non-preventive care, is $1,500. Kai has already met $500 of the deductible before the gutter accident, secondary to a lawnmower mishap. So the deductible balance, or what Kai currently owes towards the deductible, is $1,500 minus $500 he paid before, and that equals $1,000. To calculate the balance owed, we take that $10,000 allowable minus the $1,000 towards the deductible, and that equals $9,000. Enter coinsurance. Now that Kai's deductible is met, the remaining $9,000 is shared. Remember that Kai's remaining balance is $9,000. That's the amount after the $1,000 owed towards the deductible. Coinsurance. Kai owes 20% of the remaining allowable amount after the deductible has been satisfied. So $10,000 allowable minus $1,000 paid towards the deductible equals $9,000. 9,000 times 20% equals $1,800. So the total officially owed by Kai is $1,000 of the deductible plus $1,800 coinsurance, and 1,000 plus 1,800 equals $2,800. Looking at what insurance pays to the hospital, the $10,000 allowable minus the $2,800 deductible and coinsurance paid by Kai equals $7,200 that will be paid by the insurance company. Note, even though the charges were $30,000, Kai is only responsible for $2,800. Once the hospital bill for his arm fracture has been paid, Kai has spent $3,300 toward his $7,500 limit or out-of-pocket maximum. Remember that $500 deductible paid previously plus $2,800 for a broken arm equals $3,300. Kai still has $4,200 left until the out-of-pocket maximum is met. If Kai develops a post-operative infection requiring hospitalization and IV antibiotics and incurs expenses beyond the $7,500 MOOP, the insurance company will pay 100% of all covered costs for the remainder of the plan year. Kai used an in-network hospital for his care. Let's look at what that means. Understanding your needs and those of your household is the first step towards choosing an appropriate health insurance plan. Odds are, if your insurance is being covered by your employer, all the plans will be from the same carrier, such as Anthem or United. However, they may vary by their benefit structure, including the network arrangement or how much you're required to contribute towards the premium. Networks impose restrictions on access to providers and can vary from more to less limited. The degree of restriction, in turn, influences the cost of the policy. The three most common types of plan networks are HMOs, EPOs, and PPOs. Of these three, HMO plans typically have the lowest premiums, require referrals to see specialists, and do not offer any coverage for out-of-network providers except in emergency situations. Coverage in these plans is typically limited to a specific geographic area, such as only Western Kentucky or only Kentucky. EPOs, or exclusive provider organizations, are health insurance plans that usually allow access only to local providers and emergency out-of-network coverage. However, they don't require referrals. PPOs, on the other hand, typically have the largest networks, which may be nationwide. Not surprisingly, the premiums for PPOs tend to be the highest. Most coverage programs have what are called network structures, which govern who you can see and what you will pay for healthcare services. Whether a provider is in network or out of network is based on whether or not they have a contract with that particular insurance company, plan, or program. Networks exist to control cost and purportedly quality. They can make it difficult, if not impossible, to obtain necessary care, especially for those who live in an area that has few providers overall or who have conditions that require specialists or the use of a major referral center. In-network refers to health services providers who have a contract with a particular insurance plan to deliver care at pre-negotiated rates. Depending on the size or leverage of the organization providing the care, the idea of negotiated rates may be more in theory than fact. Out of network, on the other hand, refers to any healthcare provider or facility who do not have a negotiated contract to deliver services under your health insurance plan. Some plan structures do not offer any out of network benefits, which means if you use an out of network provider other than in emergency situations, the plan will not cover the care at all. Other plans do offer out of network benefits. However, in those cases, the member responsibility is typically greater than when using in network providers or facilities. For example, a plan may require 20% coinsurance for in network care and 30% coinsurance for out of network care. Using out of network providers can and almost always will result in much higher out of pocket costs than seeing in network providers. Finally, let's define allowed amount. This is the negotiated amount that providers have agreed to be paid for covered healthcare services. It may be also called eligible expense, payment allowance, or negotiated rate. Write-off adjustment, which is also called the contractual adjustment. It's the difference between the amount a provider charges for a given service and the allowable amount for that service. If a provider participates with an insurance company or a government plan, such as Medicare or Medicaid, and agrees to accept patients under that payer's plan, the provider can't collect more from the payer and the patient combined than the allowed amount. This is an example of where to find the allowable and write-off amounts on the explanation of benefits, or EOB. An EOB is generated for every claim. It will either be mailed to you or available through your insurance company's online portal. While it may say not a bill, it is extremely important and you should review it and compare it to every medical bill you receive. The EOB shows how your insurance company is handling your claim, what services you received, how much the provider charged, what cost your plan allows, how much, if any, the insurance company is paying your provider, and whether and how much you owe for the services you received. The EOB will also show how much of what you owe counts towards your deductible and out-of-pocket maximum. So notice the billed amount, the amount a provider charges, and then the allowed amount, that contractual adjustment column. And then the GRC/RC amount, the difference between the billed amount and allowed amount. So this is the write-off adjustment on this EOB. Over 60% of insured Americans obtain coverage through private carriers, either through their employers, Medicare Advantage plans, or on the marketplace. Some important things to know about employer-sponsored plans. They may provide single or family coverage. The amount an employer pays towards premiums can vary, as can the amount employees are required to contribute. Premium tax credits and subsidies cannot be used with employer-sponsored plans, and employer-sponsored plans might also offer FSA, HRA, or HSA programs. If you have affordable employer-sponsored healthcare coverage, great, you're lucky. However, if you're a small business owner, have unaffordable employer-sponsored coverage, are self-employed or unemployed with too much income for Medicaid and too young for Medicare, and you don't qualify for military coverage, you may be able to purchase health insurance on the marketplace. The marketplace is where U.S. citizens who aren't in jail or in prison, who live in the U.S. or are legal U.S. residents, can buy individual ACA-compliant health insurance plans. Fortunately, Kentucky has a state-run marketplace program known as kynect. People who live in states that don't have their own marketplaces have access to the federal marketplace. Somewhat counterintuitively, premium costs on the state-run marketplaces tend to be lower than those on the federal exchange. Plans on the marketplace are arranged by tiers, which refer to benefit levels. Bronze plans will have lower premiums and higher out-of-pocket costs compared to silver. Silver will have lower premiums and higher out-of-pocket costs than gold, etc. Kentucky's marketplace does not offer platinum plans. As a direct result of the One Big Beautiful Bill Act and the failure of Congress to continue the enhanced premium subsidies, premium costs for those purchasing insurance on the marketplace have risen dramatically. Marketplace or kynect plans are all ACA compliant. What that means is the plans provide all of these services in accordance with the Affordable Care Act or the ACA. Services like behavioral health care treatment, prescription drug services, preventive services, rehab services, among others, are required to be covered by these plans. An important feature of the Affordable Care Act is a requirement that commercial carriers must allow dependents to remain on their parents' insurance policies until age 26. A substantial number of people who purchase coverage for their households on Kynect will qualify for income based discounts on their premiums or out of pocket expenses, such as deductibles and copays. There are two types of discounts available. A subsidy or premium tax credit is a tax credit or discount used to lower the monthly insurance payment, i.e., premium. The amount of tax credit is determined by the household's income and is only available for insurance plans purchased on the marketplace. As a rule, the lower the household income, the greater the subsidy. Subsidies do not apply to group or employer sponsors healthcare coverage. They can be used with any of the marketplace tiers, which in Kentucky means gold, silver, or bronze plans. Cost sharing reductions, or CSRs, are discounts for marketplace plans that lower the amounts for deductibles, copayments, coinsurance, and out of pocket maximums. Only plans in the silver tier are eligible for cost sharing reductions. Due to the failure of Congress to extend what were known as enhanced premium subsidies, the amount of the CSR discounts and the number of people who qualify for them has decreased significantly as of January 1st, 2026. There are two times people can enroll in marketplace healthcare coverage. Open enrollment is the annual period when individuals can get, renew, change, or cancel their healthcare coverage. Failure to sign up during this time can result in being uninsured for a full year until the next annual open enrollment period. The OBBBA has shortened the annual enrollment period by a month. Starting in 2026 for the plan year 2027, marketplace open enrollment officially ends on December 15th. However, states that run their own marketplace programs are allowed to extend enrollment until December 31st, which Kentucky plans to do. A special enrollment period is the time outside of the regular open enrollment period where people are able to sign up for healthcare coverage. Qualifications for a special enrollment period include certain life events such as loss of healthcare coverage, moving outside of the prior coverage area, getting married, having a baby or adopting a child, or if the household income falls below a certain amount. Qualified individuals and families can enroll in Medicaid or in the Children's Health Insurance Program, CHIP, at any time. You can learn more at marketplace.cms.gov. Most employer-sponsored plans will also have an annual open enrollment period. However, the timing can vary from one employer to another. Connectors can help those seeking coverage to navigate the Kentucky marketplace. They assist individuals and small businesses with eligibility issues and enrollment forms. Additionally, they help people with applying for Medicaid and qualified health plans or QHPs. Flexible spending accounts, or FSAs, health savings accounts, or HSAs, and health reimbursement arrangements, or HRAs, are all types of accounts that can be used to pay for health-related expenses known as qualified medical expenses. However, they differ with respect to who can contribute to them and other details. They are not available to people on government-sponsored coverage such as Medicare or Medicaid. These programs all allow you to pay for qualified healthcare expenses with tax-free money, i.e., dollars on which you do not pay income taxes. However, they differ in who contributes to and controls the funds. The amounts which you or your employer can contribute historically have changed from one year to the next as determined by the IRS. Flexible Spending Account, or FSA. You and or your employer can contribute to an FSA. There's an annual cap, $3,400 in 2026, on the amount that can be contributed by an individual or on one's behalf. FSAs are considered use it or lose it funds, although a certain amount may be able to be rolled over from one year to the next with an upper limit of $680 in 2026. FSA funds cannot be invested and do not earn interest. Unused FSA funds are returned to the employer. Health Savings Account, or HSA. HSA savings accounts can be offered by an employer or may be available with certain marketplace plans. Similar to FSAs, they can lower healthcare costs by using untaxed money to pay for deductibles, copayments, coinsurance, medications, and other qualified healthcare expenses. They generally may not be used to pay premiums. They can be rolled over from year to year, and they remain with the employee upon termination of employment. Total annual HSA contributions must stay within an annual limit determined by the IRS, which is $4,400 for an individual or $8,750 for a family for 2026. An additional $1,000 contribution can be made for those over age 55. Note that HSAs can only be used with what are called high deductible health plans. The IRS determines the limits for what constitutes a high deductible health plan. It's related to the deductible and the out-of-pocket amounts associated with the plan. The lower limit of the required minimum deductible for a high deductible health plan varies from year to year. In 2026, this is $1,700 for an individual deductible and $4,300 for the family deductible. So, for example, in 2026, a plan would have to have an individual deductible of at least $1,700 to be considered a high deductible health plan. High deductible health plans also have different maximum out-of-pocket limits than non-high deductible health plans. The most that a maximum out-of-pocket cost can be for a high deductible health plan in 2026 is $8,500 for an individual and $17,000 for a family. This is different than the highest allowable max out-of-pocket for non-high deductible health plans. Health Reimbursement Arrangement, or HRA. A health reimbursement arrangement is an employer-funded spending account from which employees are reimbursed tax-free for qualified medical expenses up to a fixed dollar amount per year. Unused amounts may be rolled over to be used in subsequent years. HRAs are sometimes called health reimbursement accounts. The employer, not the employee, funds and owns the account. The money in HRA accounts remains with the employer upon an employee's departure from the company. A key difference between HRAs and FSAs or HSAs is that HRAs can be used to pay premium costs. Key highlights. If the insured person's account is a health savings account, they own the account. If the account is a health reimbursement arrangement or flexible spending account, the employer owns the account. The insured individual must have a high deductible health plan in order to have a health savings account. Both the employee and the employer can put money into the account if it's a health savings account or a flexible spending account. Only the employer contributes to an HRA. Only HSA funds can be invested and earn interest. Medicaid provides free or low-cost health care coverage to qualified people of all ages with low incomes, including children, pregnant women, older people, and people with disabilities. With Medicaid expansion in Kentucky, it is available to adults aged 19 through 64 with incomes up to 138% of the federal poverty level, and to pregnant women with income up to 200% of the federal poverty level. Medicaid covers everything you see here: preventive care, child dental and vision care, doctor visits, prescription drugs, mental health services, and hospital care. Low-income people with Medicare may be eligible for both Medicare and Medicaid, a classification known as dual eligible. There's also a special Medicaid program for kids. In Kentucky, it's called KCHIP, or the Kentucky Children's Health Insurance Program. This healthcare coverage is available for kids under 19 years of age who live in households with incomes of 218% or less of the federal poverty level. So, for example, in the year 2026, the federal poverty level for a family of three is $26,650. 218% of that is $58,097. If a household of three, two adults and a child, has an income of $58,097 or below, the child in that home would be eligible for K-CHIP. Here's information on how to apply for Kentucky Medicaid and how to talk to a connector. Go to connect.ky.gov to get started. Medicaid used to be free to patients. The OBBBA imposes copays of up to $35 per service for those whose incomes are 100 to 138% of the federal poverty level. Some services are exempt. Let's briefly discuss Medicare coverage. Medicare, as you're likely aware, is for those who are 65 years of age or older, certain people younger than 65 with disabilities, and those with end-stage renal disease. Medicare can be really confusing. There are 4 parts to Medicare. Part A covers hospitals, hospice, and skilled nursing care. There's no charge to most Medicare beneficiaries for Part A premiums, but deductibles and coinsurance apply. The Medicare Part 8 deductible per hospital admission for 2026 is $1,716. In addition to the per admission deductible, there is a daily coinsurance charge for hospital stays over 60 days. Part B covers doctor services, outpatient care, and preventive services. The cost of Part B premiums vary according to income level, with higher income individuals paying more on a tier-based schedule. Costs also include an annual deductible and 20% coinsurance. Part C is also known as Medicare Advantage. Coverage is the same as Part B. Medicare Advantage benefits may also include dental and vision coverage, fitness, and meals. It's provided by private insurance companies and requires payment of Medicare Part B premiums. Some plans have additional premium costs. These plans may impose restricted networks, pre-authorization requirements, and referrals for specialist care. Part C usually covers medications. As an aside, Medicare Advantage is estimated to cost between $7 billion or $321 per person, according to data from 2019, to as much as $88 billion more per year than traditional Medicare. However, it doesn't necessarily produce better outcomes. Part D, this is for medications only. It's administered by private companies. For 2026, there is a $2,100 limit on maximum out-of-pocket costs for covered medications. Costs vary according to the plan and income level. Be aware that if you do not sign up for Medicare within the required time frames, financial penalties are imposed that can last your lifetime. Even though Medicare Advantage is also known as Medicare Part C, rather than being a part of Medicare, it is actually an alternative to traditional Medicare. Medicare Advantage plans are administered by private insurance companies approved by Medicare and bundle Part A, Part B, and often Part D coverage into a single plan. They may include additional benefits such as vision, dental, and wellness programs. Medicare Advantage plans typically operate under managed care type arrangements, including health maintenance organizations or HMOs, preferred provider organizations or PPOs, and private fee-for-service plans. Individuals who do not sign up for Medicare Advantage plans have the option to select a Medigap policy. Medigap policies are sold by private insurance companies and are used to help pay out-of-pocket costs for services under Medicare Parts A and B, such as the coinsurance and deductibles associated with Parts A and B. For example, the 20% coinsurance required for doctor's visits under Part B, or the hospital deductibles for Part A. Eligibility requirements are the same as for Medicare Part A. If you sign up for a Medigap policy when you are initially eligible for Medicare, you cannot be denied or be charged more for coverage, regardless of your medical status. The providers for Medigap are providers that accept Medicare. There are 10 different standardized Medigap plans. You can learn more about them on the Medicare website at medicare.gov. Another really important thing to know is that if you opt to go with a Medicare Advantage plan and you decide after a few years that it no longer meets your needs and you want to switch to traditional Medicare, Perhaps you want to spend part of the year in a different state, or you have multiple medical problems and the pre-authorization requirements are preventing you from getting the care that you need. It can be very expensive or even impossible to obtain a Medigap policy because the guaranteed issue rule no longer applies. While both traditional Medicare and Medicare Advantage are underwritten by the government, there are key differences in how they are run and how they function. Traditional Medicare is administered by the federal government. The program usually involves higher out of pocket costs, including deductibles and coinsurance, although beneficiaries can supplement coverage with Medigap policies, as we just discussed. On the other hand, Medicare Advantage plans are run by private companies. The government pays these private plans a certain amount of money per enrollee per month to administer the plans. If the plans pay out less in benefits and overhead than they receive from the government, they get to keep the difference as profit. Medicare Advantage plans may offer lower premiums and out-of-pocket expenses compared to traditional Medicare. They may also offer perks such as gem memberships. However, they frequently require copayments or coinsurance costs for services, and they can and do restrict the choice of providers that patients can use. For example, they may limit choice to only one cardiology group or hospital in town, or they may restrict the geographic distribution of providers, such as covering only providers within a particular county or state. Another important difference is that Medicare Advantage plans typically employ pre-authorization requirements for various services, while this used to be rare with traditional Medicare. However, traditional Medicare is now piloting pre-authorization policies in 6 states: Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington, although not in Kentucky at this time. Medigap and Medicare Advantage plans. A Medigap policy is different from a Medicare Advantage plan, or Part C. A Medicare Advantage plan is an alternative to traditional Medicare, whereas a Medigap policy is a supplement to traditional Medicare coverage. You can only have a Medigap policy with traditional Medicare coverage, but not with Medicare Advantage. If you find you don't care for Medicare Advantage after you choose it for the first time and want to switch back to traditional Medicare, you have 12 months to re-enroll in the Medigap policy you had if the company still sells it. Beyond this trial period, you may find it more expensive or even impossible to purchase a Medigap policy, depending on your health situation. There are 2 time periods when you can make changes in your Medicare or Medicare Advantage plans, but they differ slightly in what you can and cannot do. During Medicare open enrollment period, which runs between October 15th and December 7th each year, you can join, switch, or drop a Medicare Advantage plan. You can change from traditional Medicare to Medicare Advantage or from Medicare Advantage to traditional Medicare. You can also change your Medicare Part D coverage if you have traditional Medicare. Coverage begins on January 1st as long as the plan receives your request before December 7th. Medicare Advantage open enrollment period takes place between January 1st and March 31st of each year, and contrary to what the name would imply, is for those already enrolled in Medicare Advantage. During this time, you can make the following changes. You can change to another Medicare Advantage plan with or without drug coverage. You can discontinue your Medicare Advantage plan and go back to traditional Medicare. Additionally, you'll be able to sign up for a Part D drug plan. You cannot go from traditional Medicare to Medicare Advantage plan during Medicare Advantage open enrollment unless you are within the first 3 months of getting Medicare. You can only make one change during a Medicare Advantage open enrollment. Coverage begins on the first day of the month after the plan receives your request. Keep in mind that if you leave a Medicare Advantage plan to go on to a traditional Medicare plan and you want to purchase a Medigap policy, as I've noted, your health conditions can affect your premium rate and whether or not you are able to obtain Medigap coverage. For assistance in Medicare enrollment, you can contact your state health insurance assisted program, SHIP. SHIP provides information, counseling, and assistance to seniors and disabled individuals, their families, and caregivers. This service is provided at no charge. You can get more information on SHIP by going to shiphelp.org. I briefly wanted to address the major changes in coverage that are coming down the pike. It is estimated that nationally about 17 million people are at risk of losing coverage, including 250,000 to 300,000 in Kentucky. The OBBBA and Congress's unwillingness to extend the enhanced premium subsidies are going to make it far more difficult for people to have health care coverage in the U.S. There is a reduction in marketplace open enrollment period, 45 days instead of 75. Medicaid eligibility verification will be every 6 months instead of every year. There will be a significant increase in paperwork and bureaucratic hurdles for Medicaid and marketplace recipients. And Medicaid copay requirements will serve as barriers to necessary care. We have a lot of people whose quality of life and actual lives depend on Medicaid. Kentucky is the state at risk for the highest number of hospital closures, with 35 hospitals at risk for closure. Unlike the US, other high income countries such as Canada, Switzerland, Norway, Germany, and England provide coverage for everyone, reducing patient stress over medical costs and improving access to care. These flags represent just a small sample of the many countries globally that prioritize a universal coverage model of healthcare access. Healthcare coverage in the US is super complicated and very expensive. It requires action and continued vigilance to obtain and maintain coverage. However, the more you know, the more likely you are to be able to identify and procure coverage that best meets your medical, social, and financial needs, and to use the coverage benefits to your best advantage. Thank you for attending this healthcare coverage overview session. Last step, please take our survey. The QR code is the one on the left. It helps show our funder that people are using this material and increases the chance that we will be able to continue to provide useful information on healthcare coverage in the future. The middle QR code will take you to our educational materials on the TAI website. We have a lot of amazing free resources on our website, and I encourage you to check that out. If you are interested in staying up to date with the Asclepius Initiative, there's a lot of great information that we share on our monthly newsletter. Feel free to scan the QR code to the right to sign up for that. We don't do anything with your information other than send you a great newsletter every month. You can follow us on the following social media sites. We're on LinkedIn, Facebook, Instagram, Blue Sky, and YouTube. I want to thank the Kentucky Department for Public Health and their grant that lets us bring this information to you at no charge so that people like you and me can get the resources we need to better understand our healthcare coverage.